Hi, good afternoon, everyone. Thank you so much for joining for this conversation. My name is Ruth Morin. I'm a clinical neuropsychologist at the Pickup Family Neurosciences Institute at Hoag Hospital in Southern California, Newport Beach. And I'm also an associate research scientist through the San Francisco VA healthcare system. I'm looking forward to hopefully a generative discussion today. So, what I'm going to do today is give you an overview of the current challenges that we face in the aging and dementia space. Many of you might be familiar with some of these numbers, some of these challenges, but I want to take a look at the bigger picture because as a neuropsychologist, what I am often trying to do is to look at the bigger picture of the whole person in their context. So, I'm going to start out on a broader scale and then go more to the level of the individual in the context of a dementia care setting. So I'll talk about neuropsychology, what it is, what a neuropsychologist does on a care team. And I want to focus specifically on factors additional to neurodegenerative processes that can influence cognitive decline and functional status. I'll spend some time talking about pain points and a personal wish list for some things that I think AI is poised to really support in the future, and then really looking towards what's next and hopefully a conversation with all of you about what are the challenges you see ahead and what are some of the solutions that you can see as well. So I will plan to go through my presentation. You can feel free to put any questions in the Q&A box in real time, and I will plan to address them at the end of the talk, or Anne can help with answering questions in the moment that might come up specifically about the AITC. So I want to start with this framework for the conversation because I'm going to share a lot of numbers that are pretty staggering and concerning and a lot of challenges. But this quote from Dario Amodei, the CEO of Anthropic, from a really inspiring essay that he wrote called Machines of Loving Grace, which I highly recommend, that I think it's critical to have a genuinely inspiring vision of the future and not just a plan to fight fires. So that's something that I want to think about, not just how do we, address these problems as they come up for our patients, for our communities, but how can we imagine a better, more equitable, a more peaceful, healthy future for all of us as we age? Okay, so I want to talk about some of these numbers. This is from a recent article that just came out of the showing the lifetime risk and projected burden of dementia. So many of you are probably familiar with the numbers around the aging of the populations. By 2030, 1 in 6 individuals will be over age 60. And between now and 2050, the population of those over age 80 is expected to triple. These new numbers about lifetime risk are pretty shocking, frankly, being 42% for individuals over 55, the lifetime risk of developing dementia, which is quite high. And we know from the article that these numbers are higher among women and individuals of minority groups. So this is a significant concern for all of us as we age. And right now, dementia affects nearly 7 million Americans. So that's more than 1 in 10 older adults in the United States. And we know that this number is expected to drastically increase with the aging of the population. So, for example, in 2020, their prevalence yearly of new dementia cases was over 500,000. It's expected to be 1 million per year by 2060. So we also know that this is likely an undercount for a variety of reasons. It's underdiagnosis, there's delayed care that people are reticent to seek for a variety of reasons, and that this can vary significantly by different intersectional factors. So these numbers also have a significant impact on the healthcare system. Dementia currently accounts for over $600 billion in US healthcare spending annually. Costs related to dementia care account for about 1% of global GDP, which is expected to double by 2030. And in terms of just sheer burden on individual hospital systems, older adults with Alzheimer's disease and related dementias account for about 1.5 million emergency department visits every year. So this is costly, it's very challenging to manage in a care setting, and it's really impactful. You can say that, okay, great, we've got these new disease-modifying therapies. Some of you might be thinking this is certainly likely to change. Well, unfortunately, that is not necessarily going to be the case so quickly. While it's wonderful to have some interventions that can slow down a cognitive decline early on in the disease process, it's a critical period that in the clinical trials is measured over the course of 18 months, which might temporarily ease the burden and give people a few good years, a few functional years before the decline continues to progress. But that critical period is often really impacted by the fact that wait times for a confirmatory diagnosis, some of the other tests that are required in order to be eligible for these treatments, can take as long as a year. So things like PET scans, a neuropsych assessment, other blood-based tests. We also know that the average wait time to see a dementia specialist in the United States is 20 months, with 34 to 59% of older adults living in what are considered to be dementia neurology deserts, where they don't have access to a care provider. We also know that the individuals in these clinical trials are what I might consider to be a best case scenario, as much as possible, a pure Alzheimer's disease. Younger individuals with fewer cerebrovascular comorbidities, without depression, without many of these factors that we very often see in patients in our clinic. And so that, in combination with the fact that many of our care providers are not only not comfortable having conversations about realistic expectations with these treatments, but often aren't educated about the clinical trial population in a way that can help them provide realistic expectations to patients and their families. I've certainly heard many caregivers say that they feel that there was some false hope offered in the mainstream media coverage of some of these therapies relative to their loved ones, and has actually created some real tension in the care team in trying to advocate for their loved one to receive some therapies that they might not be appropriate for. And it's been challenging for their care providers to explain adequately why that's the case, especially when they're really hoping for something transformational. So it's wonderful we have these treatments. We should continue to search for every possible prevention, intervention, and this is certainly not a magic bullet. So when we think about the impact on the care force, not just the healthcare force, but the care force, we know that more than 11 million Americans provide unpaid care for someone with dementia. In 2023, this was equivalent to 18.4 billion hours and $346.6 billion in unpaid labor. 70% of the cost of lifetime care for dementia is borne by unpaid family caregivers. So this is a significant economic impact as well. An individual who's diagnosed with Alzheimer's at age 70 and lives for 10 years. Also know that on average, we'll spend 40% of that period in a severe disease stage, which means that we expect them to need assistance not only with instrumental activities of daily living like finances, medication, and schedule management, but also more basic ADLs like bathing, toileting, transferring, things that can be very physically challenging, and along with the emotional challenges for family caregivers. So, who are these caregivers? The Alzheimer's Association annual report from 2024 shows us that, like many things, this care force is impacted by intersectional factors. Two-thirds of dementia caregivers are women. Most caregivers live with the person with dementia in the community. Over half of caregivers are providing assistance to a parent or an in-law. 41% of caregivers have a household income of $50,000 or less. So not only is their labor unpaid, they're already very financially vulnerable and may be less likely to be able to access some of the resources that might be available to them or to advocate effectively for themselves and their loved ones. We also know that about 30% of caregivers are age 65 or older. Something that I see very often in my clinical practice is a patient with a spouse who is also exhibiting some signs of cognitive impairment. And Very often, they don't have a loved one close enough to them geographically to really be able to step in and assist. And so, what you're seeing, what it feels like to me in the room, is this kind of slow moving disaster impending for this family unit that's really difficult to mitigate, especially when the insight is low into the deficit and the need for support. On a human level, we know that 59% of dementia caregivers report very high emotional stress from caregiving. 38% report very high physical stress. There are high rates of depression, anxiety, and poor health, particularly among women. And dementia caregivers have a significantly greater risk of cognitive decline than non-dementia caregivers. We know that individuals feel a sense of duty to take care of a family member, so that's a factor in their decision. And over half of individuals who are care providers say that their primary priority in providing that unpaid care is to keep a loved one home. That can be for financial and logistical reasons, that can be for cultural reasons or values-based reasons, but regardless, often that requires even more of a sacrifice on their part, and people can feel that they've failed if their loved one ends up requiring a higher level of care than they're able to provide in the home, which most people who die from or with dementia in older age will require some additional assistance. So this is very difficult in the aftermath, especially of a loved one's care transition or passing on the family member with significant ramifications for their own health. Okay, so what do we do about this? These are obviously exceptionally challenging multimodal social problems, but I believe that AI is poised to revolutionize and ease nearly every aspect of some of these issues that I've just discussed, from diagnosis, treatment, and more specifically, care and management in the community, in somebody's context and environment. And I believe that more than ever, collaboration and insight from multidisciplinary stakeholders is critical in order to be able to bridge this gap and move us forward in a positive way. So this is clearly a non-exhaustive list, but I want to think about some of the challenges that I personally see just from my own clinical practice and opportunities for the era of AI and dementia care. So I think, AGI is coming at some point, which is great, except there are things that we really need to consider and actually on a very near-term timeline, given the accelerated advances for how these things are going to be managed, because it's my sense that people desperately desire to approach these problems in a sensitive and ethical way, and that can often delay the implementation, innovation of some of these interventions, which are desperately needed. So some of the challenges that I see, that there are ethical concerns, especially with individuals who don't have the ability to really understand what the implications are for certain types of monitoring, for example. There are issues about access, certainly issues of consent, especially in individuals who are incapacitated by cognitive impairment. We have provider burden, we have provider burnout in trying to implement anything additional into their workflow when there is already such a high administrative burden. And we know it can be very challenging to implement anything new into a rigid system, into a rigid care system. Another thing that I've witnessed is that there's often a poor fit between the product and the user ability. So there is a genuine desire to create a product or a use case for a particular population. There might be certain things or many things that are missed by the creators of that product because they don't have a good understanding of some of the challenges those individuals are dealing with. So that's why, again, the collaboration and some of the opportunities provided by a mechanism like the AITC are so important because everyone that's involved can utilize their particular viewpoint to really solve some of those challenges. I also think there are tremendous opportunities. So I think there's tremendous opportunity to have relief for caregivers, reducing healthcare costs and touch points. When people stay out of the hospital, out of the emergency department, their prognosis is better. It might allow us to streamline care, keep individuals in their homes, which is often people's value to stay home and as independent as possible, as long as possible. And I believe that advances will allow us to balance the safety needs with independence and autonomy. and then mostly better quality of life. Because if we're so focused on a disease process, we can really miss the opportunity to improve a quality of life while living with dementia, which is going to be is the reality now, and will be the reality for many millions more Americans in the future. I think one critical challenge is that often in these conversations, I feel that dementia is treated as a unified construct, as opposed to a deeply multifactorial, heterogeneous disease process that both impacts and is impacted by nearly every aspect of a person's health, their family system, their culture, their upbringing, their neighborhood, their social support system, and impacts all those factors. So I really think this is an opportunity to use AI to bring truly personalized medicine into the dementia care space, but it requires seeing every individual on their own terms. And that's where I actually feel that neuropsychology has a unique perspective to offer in this conversation because that's so much of what we have an opportunity to do on a care team. So I want to talk a little bit about what neuropsychology is, what we do in our assessments, and some of the things that we have an opportunity to touch on that are maybe missing from other conversations with providers that have a shorter opportunity in their appointment time to speak about the issues related to cognitive decline. So, neuropsychology is the study of brain behavior relationships using standardized assessments to investigate various aspects of cognitive functioning and its impact on daily living. The thing that I think is most salient about our role on a care team, sometimes we're directly embedded in a dementia or memory clinic, other times we're in independent practice. We're always consulting with referring doctors, whether that's a neurologist, a primary care, family, or geriatric medicine doctor, or even a social worker. But we have a lot more time to spend with patients and their families than other physicians do. We speak with them at length. We speak with their family members at length, often separately. We have a chance to observe them over the course of several hours in the context of complex cognitive assessments. Oftentimes, family members will say to me, my mom, my dad can really fool their doctor in 15 minutes because they're very charismatic and they can keep it together for 15 minutes an appointment. But if you give them longer than that, they start to repeat themselves. They start to have trouble. And one of the things that's nice about having a 4 hour appointment is we have an opportunity to witness some of those things. And the specific pattern of those types of behaviors allows us to get a better sense of what's happening in the brain, but most importantly, to tailor our recommendations to support patients and their families. So we do this through the use of a neuropsych assessment. And a neuropsych assessment utilizes standard cognitive assessments, usually paper and pencil, but some computer-based. We want to measure a variety of different cognitive functions, different domains like memory, attention, language, executive functioning that correlate to the functioning of certain brain areas that are related to different neurodegenerative processes. And we compare an individual's performance on those tests to demographically similar peers using normative data. So we're not comparing an 85-year-old to a 20-year-old. We're comparing someone to their demographically similar peers. It usually occurs over the course of several hours, as I mentioned, on one or more day, typically in an outpatient setting, but can also be in an inpatient setting. We generate a report with a summary of the results, including the scores, an impression of the findings, including diagnosis, and recommendation to support the person's health moving forward. Oftentimes, we provide feedback both to the referring doctor and to the patient and their family as well. So what is in an assessment? We have a clinical interview where we discuss with the patient and their family, their background, their education and work history, the history of the onset of the cognitive changes, their emotional functioning, their functional status, medical history, any other pertinent information. We do a chart review. We look at clinical notes from the referring provider, any imaging, labs, medications, things that can be relevant. Get report from a loved one. We have the objective cognitive test data, some symptom questionnaires, usually around different aspects of emotional functioning. And then we have our own observations of the patient and their family and the environment. So we really are able to get a snapshot from all of this of a moment in time of a person's cognitive functioning and some of the challenges that they're facing. We understand that this is impacted by a variety of factors beyond neurodegenerative changes. So we try to look at the whole person and the whole picture, the pattern of data in the context of their reported history and their cognitive and functional status, along with other factors. So we get the most information at once, and I do believe that this allows us to think very creatively, both about the diagnosis, but also about the care planning and identify some of the challenges that this family system might face. So aside from neurodegeneration, these are some of the things that we consider and talk about as having significant impacts on cognitive functioning. So there's the neurodegenerative process itself. There's medication with cognitive side effects, especially among older adults. There's behavioral and neuropsychiatric symptoms, which can be both a comorbid psychiatric diagnosis, either along with the dementia or predating it, or behaviors that coincide with the neurodegenerative process itself, poor quality or quantity of sleep, stress, pain, other medical conditions, sensory changes. This is really just to name a few. But the helpful thing about our assessment is in identifying these various factors, we know that there is a different neuropsychological signature. And what I mean by that is the pattern of test scores is impacted by all of these factors, including the neurodegenerative changes. So we're really able to think about what areas are going to be most impactful for intervention for that particular patient and family system. So I want to think about these different risk factors as inverse protective factors. So every risk factor is actually an amazing opportunity because we don't have a cure for these neurodegenerative diseases. We can maybe slow them down, but again, a lot of these therapies only function on one protein. We know that many people, most people on autopsy will have evidence of multiple neurodegenerative diseases in their brain. So, what are other things that we can do to intervene? We know from the most recent Lancet Commission report that 45% of dementia cases or risk is potentially modifiable across the lifespan. So, that's a lot of opportunity for us to intervene. And even once there is cognitive decline, we can intervene on these factors both to reduce kind of the severity of the impact of the cognitive decline, but also to improve quality of life. And the way that I would say other industries are asking themselves, how can AI help with this? Every point of somebody's workflow, I really believe it's imperative in healthcare for us to do this as well, no matter how exhausted and burned out and overwhelmed with patients we are, because I do think that we can approach these problems more creatively when we keep this question top of mind. So here are some examples of things that have come out in the last few years. You can certainly look on the Hopkins AITC website or any of the AITC websites to see some of the amazing proposals that have come through. These are some amazing studies that have talked about identifying cognitive status, diagnosis, staging and diagnosis. This is all wonderful. And I was just speaking about some of the many things that can impact cognitive functioning that aren't just the neurodegenerative process. And the challenge of some of these technologies is it doesn't necessarily differentially identify what is some of those other factors kind of impacting and what is the disease process itself. And so I think there's an opportunity and an imperative to be really specific about what we're measuring and measure more things more selectively in order to be able to identify what is what. So this brings me to a little bit of a conversation about kind of the healthy pathological aging dichotomy, which I think is a challenge in our conversation around these issues. I believe that underdiagnosis is partially a function of misunderstanding the difference between healthy and pathological changes with aging. So many people will say, oh, we just thought, they'll come to me, they'll say, well, I've noticed that my parent has had some memory loss for the last 5 or 10 years, but I just assumed they were getting older, or I just assumed they were lonely because of the pandemic, and they really missed their critical window for the few treatments that are available to slow down a decline. So I think that's one thing that we really need to intervene on, both in terms of education and thinking about how to tailor these interventions. But I really believe that AI has the potential to dissolve this barrier because if we're truly doing targeted, personalized medicine, we can intervene and monitor across the disease and symptom course, and frankly, across the lifespan, with focus on optimizing outcomes as opposed to arbitrarily saying, you're cognitively intact, you're mildly cognitively impaired, you're severely cognitively impaired, as if that is a stable trajectory that's linear, which we all know it isn't. The other thing is we want to shift from a focus on disease state to quality of life and functioning. This is going to be challenging in the current conversation around disease modifying therapies because we want to talk about, burden of some of these, factors that can be impacted prior to clinical onset. We know that brain changes occur more than 20 years before cognitive decline. So this is a real opportunity across the lifespan to think about interventions to really work towards true person-centered, personalized medicine. So beyond neurodegeneration, we talked about some of the factors that can impact cognitive functioning. Quality of life is not just cognition. I'm constantly blown away by the fact that when I ask a patient with a loved one with a pretty severe cognitive impairment, what's your biggest challenge? A lot of the time, they don't talk about the memory problems. They say, I'm worried about my dad answering the phone and giving his information to a scammer. I'm worried about my mom being vulnerable talking to a stranger because she's friendly and not being able to discern whether someone's safe or not. I'm worried about my father's ability to manage his catheter. I mean, things that are impacted, everything is impacted by the dementia process, but it isn't specific to the cognitive dysfunction in particular, which is why I believe that dementia care is everyone's business, every provider, and it impacts every condition, every touch point, and it really needs to be a team effort. And I really think that in order to see the whole person, you have to see the whole problem. And I believe that moving toward an N of one or N of some, maybe N of some meaning a neighborhood, a community, a care setting models to help individuals and their communities be more effective in personalized approaches is really useful. I actually think some of the way that the trends are moving towards smaller, more specific LLMs might actually coincide very nicely with this approach. So these are just a few examples of ways that AI can be useful or things that might not be considered when preparing a product to intervene in a patient with dementia or this population. So depression is a major one. Depression is associated with poor memory at baseline and steeper decline over time. When you create a product and you're measuring a patient with dementia versus severe depression or some combination of both, does it matter which thing you're measuring? I'm not sure, and I'm not sure you're going to be able to tell unless you're assessing for it. So we're not going to really be able to identify what's useful and for whom without a much more multimodal assessment, without much more sharing of data and collaboration on some of these multimodal factors. So this, opportunity, we can think about multimodal symptom monitoring of depression in addition to cognitive symptoms. We have to think really creatively about behavioral activation. All of these things, exercise, managing chronic conditions, all of these things, people know what they're supposed to do. They have a really hard time doing them. So finding ways to build these healthier behaviors into someone's day-to-day life, how to catalyze them. And that's going to be a really other important impact of some of these technologies is not necessarily on the novel intervention itself, but figuring out how to get people to engage with them. Another one is disturbed sleep, poorer attention, cognitive slowing, impaired recall. Disturbed sleep is a hallmark symptom of many neurodegenerative processes with a significant impact on the emotional environment of both the patient and the whole family system. Because if the patient isn't sleeping, the caregivers aren't sleeping, and that makes things very challenging. So maybe there are some environmental assessments, maybe there are physiological signals, maybe you can identify conducive factors to improve sleep for a patient and their caregivers. Cerebrovascular risk factors, it's a big one. We know that even a brief increase in blood pressure for a short period of time can increase risk for cognitive decline. So what can we do? Can we intervene to make sure someone's taking their medication? Can we educate primary care providers that if someone's reading is high in the office, it might not mean that their medication isn't working. It might be that they're forgetting to take it, and they might not have awareness of that fact. So how can we be creative in solving these problems? So when we think about implementation challenges, there are a lot of opportunities, but I do think it's tough to read the label from inside the box. So what are some challenges, and then how can we think about overcoming them? At the patient level, there's a real issue with comfort with technology. For many of these individuals that I see, an early sign of cognitive change is more difficulty managing technology that they always were able to manage and learning how to use new technology, which is a particular challenge at the moment as things advance very quickly. It's not just you're going to get a new iPhone every 5 years. You're starting to see these tremendous changes and overhaul of how everything is working. It's going to be especially difficult for individuals with even subtle cognitive decline to keep up. I think often there's a suspicion of motives, both in terms of the motives of the care team, but also motives of pharmaceutical companies, uh, big tech, about what the monitoring is for. I think people are understandably concerned about surveillance, how their data is being used, privacy. There's a distrust of care systems, healthcare systems, overwhelm. There's just one more thing to manage. How can I possibly implement something new? I can barely make it through the day, and decision fatigue about it being really difficult to know where to start. I always try with patients at the end to summarize what we've talked about and say, okay, here's your action plan. You have a whole list of all the things that I recommend, but this is the most important thing. Start here. So, really trying to help mitigate some of that overwhelm. And on the provider level, the same challenges I would say as at the patient level, but we also have burnout, more administrative responsibilities. So, you're telling me you want me to add something to my workflow? Take some patients off my caseload. So I know that that's a real challenge that people face. There's some real ethical uncertainty. There's a desire, I would say not enough of a desire, but a desire to integrate these technologies into practice to both streamline our efforts, make ourselves more available. There are not enough dementia providers, but there's a real concern about respecting patient health information, not wanting to utilize these models in a way that the information can be used in training data, and wanting to be very careful about those factors. And then, of course, limited time. So I think some of the key factors to keep in mind, we want to have interventions, products that are flexible. We want them to be adaptable to both the situation, the disease state, the needs of the individual patient and family. We want them to be tolerable. So even if they're helpful, if they're hard to implement, if they're labor intensive, if the app is buggy, if someone forgets to charge it, all of these things are tremendous challenges. We also want to have the ability to have these things be sensitive to change over time because that's such an important prognostic factor for care transitions in this population. We want to capture an individual in their context. This is tremendously important, something that we're not able to do in care settings. If we can integrate that information back into data that we see when we see someone every 6 months or every year, will allow us to get a much better picture of how someone is functioning. Can't tell you how many times I'll say, your testing is normal, and the family will say, they're not paying their bills. They're forgetting things. It's a mess. What do you mean the testing is normal? I'm like, well, the testing's normal, right? It's not sensitive enough and it's not seeing the person in their context. I think you want to identify your audience and adjust your product project accordingly. So even if it's for a patient, does this need to be operated by a caregiver? Is this something that a patient can manage only in an early disease stage? Is this something for someone who's cognitively intact, who is worried about having some cognitive changes and wants to be able to monitor for subtle early signs? Just really being specific about that and making sure the use and the user interface is really tailored appropriately to that population. You want to make sure you have buy-in from key stakeholders and that you're able to implement behavior change. If we can't catalyze an individual or a care system to utilize something that will help, it doesn't matter that we made it. And we also want to be able to integrate it with current rigid systems, both in care settings and in family systems and insurance settings, et cetera. So I do think that there's a lot of hope. The problem is too big to be timid in our approach here, and I believe that everyone has to be involved in whatever particular way they can. It might be that no one project is going to kind of encompass the whole problem, but I think in some ways that should relieve you of the responsibility to capture everything and just say, I'm going to focus on this one thing because I know that making even a 2%, a 3%, a 5% impact on quality of life for a patient and their family is significant. And I can tell you this is true. I've seen it. So this is my personal wish list. Don't mind me. This is for providers and researchers. These are just some things, that I think would be amazing to have. Can we have an alpha fold for dementia? Can we have multidisciplinary conversations to protect data for early adopters of these technologies? Can we really reassure our patients that their E4 status, for example, is going to be protected relative to, say, a life insurance claim or wanting to set up an insurance for the future? Now, identify audience and create a product that's appropriately tailored. So this next wish item was from a dementia neurologist I worked with. I work with closely with. We want to triage based on multimodal characteristics to optimize our wait list and, of course, ease the admin burden. And for patients, and this is a little bit of a kind of multidisciplinary wish list, but I believe we can use AI to have more direct, difficult conversations. We have to teach the next generation of clinicians to be more proactive with their confidence of how they interpret data, how they're prompting, how they are communicating with patients and families, in training that population and also dealing with patients. My experience is very challenging for care providers, for physicians to have these direct conversations. I think that's one unique um, kind of benefit of having a psychologist on the care team is we're trained specifically to have these direct, difficult psychoeducational conversations. I'm constantly amazed at how giving the worst news can be received as a relief because it provides information and education that makes a transformative difference in how someone navigates their life. Putting things out there directly allows families to have clear conversations with one another about their needs and have an anchor conversation with the provider to refer back to and share a lot of the things that they're afraid of that it's really challenging to have conversations about. So these types of interactions are crucial, and I think we can use AI creatively to figure out both how to train providers to be more effective and how to have them, frankly, and how to kind of use multimodal data to give a better sense of what people can expect. Want to tailor recommendations really specifically to the patient. We can say, here was their career, here are their hobbies, here are their values, here's what they care about. How can we make really targeted recommendations to support them? And of course, ongoing assessment and practical guidance. Protection from scams. I cannot tell you the number of millions of dollars I have heard about individuals being scammed out of. We know that there is no way to quantify the amount of fraud that's happened to our older adults with cognitive impairment in this country, and this is going to be a much greater challenge as AI advances and becomes more convincing. So this is a really, really important area of intervention, and anything that someone can do to help is transformative. I also think we need to assist with the timing of care transitions as they are necessary. So we don't can't just be waiting arbitrarily, see your neurologist in 6 months, but you needed a care transition in 2 months. Or there was a really critical issue. You ended up in the ER 3 times with agitation, but you have to wait 3 months to see a neurologist to talk about that care transition. So some of the ongoing monitoring can be useful in identifying those things and maybe connecting with someone who can help before the next appointment. Want to catalyze behavior change preclinically from early on. People are motivated to prevent cognitive decline, but behavior change is very difficult. If we all did all the things that we knew were good for us to do, we would all be much healthier. It is much easier to say them and harder to do them. So that I think is an area that can be really helpful. I personally find in my own interactions with these models, I am less defensive to feedback from ChatGPT, from Claude, than I am to feedback from peers and from loved ones. So how can we use the quote unquote neutrality benevolence of these agents, of these models in order to catalyze the behavior change? And of course, management of co-occurring conditions, which compound burden and cost. And this is significant. If we don't monitor blood pressure, we realize it takes us a year until the next Christmas to realize that mom hasn't been taking her medications or refilling her prescriptions. There's going to be much higher risk for other adverse health events, going to increase healthcare cost, increase frailty, increase burden across the board. So that's another area where there can be a lot of opportunity for intervention. And I get the best ideas from families and from patients. They're constantly bringing up problems that I would never have thought of, and also telling me about amazingly creative solutions that I would never have thought of. So I'm constantly learning from my patients, from their families, and finding ways to be directly involved. Anyone who is making these products, find ways to talk to organizations, talk to the Alzheimer's Association, provide education. People are desperate to share their stories. They're desperate to provide their insight and to be heard. So really using those opportunities. So, in the longer term, I not just thinking about AI in caregiving, for example, but maybe AI can replace non-caregiving labor of caregivers at a lower cost, and maybe that can be covered by Medicare. This is my pipe dream wish list, right? I want these stakeholders, every stakeholder, in policy conversation. I want a more equitable society. I want respect for everyone, regardless of their cognitive status. And even if AGI cures dementia this year, millions will live with cognitive impairment for decades to come. So there, these conversations are imperative to have at every level, and we all have to really do our part to be relentless in advocating for our patients and for the future of our society, frankly, as the population continues to age. So I want to end with this, which is helpful for me to remind myself. On the question of meaning, I think it is very likely a mistake to believe that tasks you undertake are meaningless simply because an AI could do them better. Most people are not the best in the world at anything, and it doesn't seem to bother them particularly much. So that is what I personally try to keep in mind and think about, what are all the ways, what are all the tools that I can use to be most effective for our patients and their families and for our own collective future. Thank you very much to the Hopkins AITC, to the organizers for inviting me, to colleagues and patients, particularly patients and families. I'm indebted in my gratitude to learning from them on a constant basis and sitting with them in really challenging moments. So I think we have some time for questions. Thank you for listening. I'm going to open up some of these questions. So one question is, could an AI model be personalized to the level of the patient's personalities? For example, they might have personality, I think personality disorders before dementia can be easily irritated at the same time confused. Absolutely. I think that is a really good question. I think there have been some papers that have come out recently about kind of generating respondents to make census data or make available kind of participants for data by mimicking responses of individuals. And so I think there's a real opportunity there where there are going to be some ethical considerations, of course, in putting that information into a model, but that would be my ideal. I think we have this idea of, and some of the proposals the AITC has already accepted have talked about this if you look at the website, but an idea of a digital twin. Can you make a digital twin? Could we all have a digital twin? And as we gather more data about that digital twin, we can test out different drugs, different interventions, see what's going to be most effective for that individual. I think that is going to be really crucial in the way that we think about how we do individualized medicine moving forward. Um, Let's see. Okay. There's a great question. So many of our ADRD cognitive assessment diagnostic tests we take are Western, mainstream in tone and content. How can diverse multicultural patient families help make neuropsych tests more inclusive? This is a key question. There's significant problems with normative data. There's significant problems with the environment of care, with our ability to support families from multiple backgrounds, multilingual families, people of different immigration statuses. So this is a huge problem, and I do think there are a lot of opportunities with AI. There are some digital cognitive assessments already, but if we can find a way to put everything we know in neuropsychology, say, into a model that takes those specific cultural factors into account, maybe we can replicate a provider that is specifically matched culturally to that patient. I would love for AI to be the new neuropsychologist. There are not enough of me. We have such a strong need, and anyone, in my opinion, in these spaces, in these care spaces, who are reticent to think about replacing themselves with models and technology are not caring for their patients. There's just too much need. So I believe that there's a real opportunity to speak to individuals who can share their own lived experience to really inform some of these interventions so they're not just receiving, the kind of passive paternalistic information that might not apply to them and their families. That's a really great point. Question about insurance coverage on neuropsych assessment for dementia. Does it need to be referred? So that depends on the insurance. Oftentimes, it will need to be referred by either a primary care doctor or a neurologist, depending on the insurance. Sometimes an individual can be self-referred. There is, I would say coverage from Medicare has been cut for reimbursement, so that can be a little bit challenging, particularly given how multimodal and time-consuming a lot of these patients are to care for. I think a referral pathway is really helpful, mostly because we are meant to be a one-time consultant. So we want to be able to share the results with a regular care provider who can check in, who can follow up, who can make sure that those recommendations are being implemented. So even if a referral isn't required by insurance, I think it's typically useful. And there's also more of a rapport with that provider on an ongoing basis. How many patients usually see a neuropsychologist regularly? Are we in serious shortage? We're in a serious shortage of geriatric providers, period, of dementia neurologists, of neuropsychologists. But I don't believe everyone needs to see a neuropsychologist. And that's why using more tailored triage to understand what someone needs would be particularly useful in opening up that pipeline. So many times I see someone who has severe depression and there isn't evidence on imaging or on testing that there is a neurodegenerative process at this moment. So could there have been a briefer assessment that would have allowed to, kind of provide those recommendations, resources for intervention without having to see a neurologist, without having to see a neuropsychologist, and use a spot in the wait list that could have been used for somebody else? At our In our institution, we have a community-based program called the Orange County Vital Brain Aging Program, where we do brief cognitive serial assessments for community members and talk about modifiable risk factors, and a change or a low score can trigger a referral to a neurologist. So things like that can be implemented in community, and I think that can be helpful in kind of making sure there is as much space as possible for people that want to be seen. Um, okay. Trying to look through these questions in real time. Would continuous monitoring of older adults solve these problems? I think it depends. I don't know that it would solve the problems. I think it would really help. We're all being surveilled on a constant basis. And so it's been my experience that many patients and their families would be willing to be monitored in order to receive assistance. So I don't know if that's the case for everyone, which is why you need to take every individual in their context. I do think more people than we think would be willing to give up some privacy in addition for, in exchange for more support and more information in real time and just-in-time interventions. I really like this question. A best practice for bridging the gap between early resistance to a potential dementia diagnosis and accepting a proactive care plan, no matter the diagnosis or outcome. So I think about this in a couple of ways. I see hundreds of patients every year. I am giving bad news to hundreds of people every year. I am amazed at how often people receive this news without much surprise. By the time they get to me, mostly people know there's a problem. And I'm not talking about individuals with lower insight. That is a particular challenge, and those people need an extra amount of support. The caregivers do, because the patient has no awareness, and the caregiver is in a very precarious position morally, where they essentially have to lie in order to take care of their loved one. And a lot of times there's a lot of ambivalence, moral injury, trauma there. And we really need to provide better education and guidance and absolve caregivers of that responsibility as much as is possible in terms of providing a structure for the support that's needed. But early resistance to a diagnosis, I find that what's so helpful about a cognitive assessment that's different from other ways of diagnosing someone is we have their scores. I'm not telling you what I think. It's not my personal opinion. Here's objective data about your test performance, and I'm taking that in combination with what your loved one is saying, what your MRI says, all of that. And so it's a little bit easier, I find, to have these conversations when you have something to show, because you can say, oh, I notice that it's less of a recall problem and more of an encoding problem. Is that something you notice in your day-to-day life? What are some ideas that we can come up with together for how to mitigate that? And sometimes an intervention as simple as telling a caregiver, I know you're just trying to test the limits on their memory, but stop saying, don't you remember we talked about this? If they remembered, they wouldn't be asking you, can really ease a lot of tension. Uh, Whether someone can accept a proactive care plan, we don't have any control over anyone's behavior, but I do think finding small ways, learning from some of the business spaces, the kind of incremental habits. If the first step feels too hard, it's too big. How can we catalyze people toward behavior change and really make some of these interventions, engagement with care, easier for people to implement in ways that positively impacts their overall health? People want to keep their driver's licenses. People want to stay in their homes. And if you say frankly, the conversation is, you are in control of many aspects of how this process goes, depending on how much you engage in interventions. Many times people are catalyzed in order to engage more effectively, but they need help. They need constant support. They need guidance. They need reassessment. They need adjustments. They need the ability to get their questions answered by a provider. And there just aren't enough of us, and we don't have enough time to do it. So I think have the hard conversation, be direct. I think everyone should be talking about cognition, and we should be thinking about this, give people permission to grieve about this. We see our cognition as a key aspect of our personality and our sense of self. It's not how we would see a cancer diagnosis. It's a lot easier to remove ourselves, giving people the tools and the language for how to discuss these problems with their family members, with their friends, so they're not isolated, so they can really lean on their community. Um, let's see, maybe I have time for one more. Um, Regarding the perception that ChatGPT is more empathic in caring than physicians. Elaborate on the role of training. Is it just the words? I don't think it's just the words. I do think it's the training and holding difficult conversations. But this is a skill you can learn because it's something that was certainly much more difficult for me when I first started doing it, and you can get better with practice. And whether that's creating a model that is a resistant patient, that is, pushing back and saying, as has said to me, I've been driving since before you were born. You're wrong. The tests are wrong. I couldn't hear the tests. The tests were stupid. I didn't sleep well. How you can deal with those conversations. That didn't work. Let's try a different approach and then provide tailored real-time feedback to the provider about what they could have done differently. Now, if you marry that with having also a model that has the personality characteristics, the cultural values of that patient, and says, here are the things to keep in mind and allow someone to practice in a low stakes way, I think it could really help in making people feel more confident they can have these conversations in person. There's so many great questions here. I don't know that I will have time um, to answer, and I will answer one more, and then I'll say, please email me. I am so it's so important to me to have these conversations with anyone who is in the space and wants to make a difference. I really believe it's a team effort here. So please be in touch. I'm happy to have follow-up conversations, answer any questions, hear your ideas, share my experience from what I've heard from patients. Any way I can be of help. Um, but I love ending on the positive. Has any work been done on the positive impact of grandkids on grandparents with dementia? I'm not particularly familiar with that. We do know that the care force of individuals 18 to 29 is growing every year, and so this is something that's impacting more and more individuals and will impact more individuals as the kind of sandwich generation ages, a generation of individuals who are caring for an aging parent and a young child. But in the data from the Alzheimer's Association talking about some of the challenges or the reasons why people engage in caregiving, a sense of tremendous meaning and personal satisfaction and love and care was also on that list. And that's something that I think really gets lost in the everyday challenges of providing care for a loved one, in flattening or inverting the hierarchy between a parent and a child, and changing the dynamic of a spousal relationship to a caretaker, care recipient, and any way that we can use technologies to put people back in their family system in the way that they should be interacting, enjoy quality time, meet each other with love and respect, and allow other kind of integrated technologies, resources, interventions to provide some of that care for them so the whole system is supported. I think it'll only increase the positive impact because it is tremendously meaningful to work with these patients. It's the greatest challenge and also the greatest honor of my life. And so finding ways to to augment that. This is a great point. Yes, and the younger generation can help them with AI. Absolutely. Absolutely. So we want to, can we provide incentives? What if we give grandchildren of, college age grandchildren who are caring for a grandparent with dementia stock options in order to implement your I mean, I think there are a million creative ways to think about how to do this and how to really get everyone involved and catalyzed for the best possible outcome for everyone. So thank you for bringing that, uh, the positive, um, the positive framework, bringing it back. I do, as as difficult as the challenges, I really believe that there is a lot of hope and that there can be a beautiful future. I'm happy to share any information on my slides. I can share references, any other conversations that anyone wants to have after the fact. Feel free to reach out anytime. And I thank you all so much for your time and excellent questions and for the work that you're doing.